that's CardioCare, and that's what it looks like. And we'll be going straight away to the presentation. Okay, so what is hypertensive emergency? Now, hypertensive emergency essentially indicates that there's a life-threatening complication to high blood pressure. Sometimes it may signify the first time a patient may be presenting with hypertension. It's estimated that 1 to 2% of patients with chronic hypertension will at some point in time get hypertensive emergency and will have need for some form of therapy. So it's a term used to define hypertensive urgency and hypertensive emergency. Hypertensive crisis, essentially the term is being put away. So what are our objectives for this brief webinar? Number one, in patients with severe hypertension, doctors, particularly primary care clinicians, should be able to distinguish between hypertensive urgency and hypertensive emergency. Number two, you should be able to ask yourself how to manage your patient. And number three, you should know what to do after making a diagnosis. Okay, I'm not wearing a face mask because I'm alone in the office. In case you are wondering. Okay, so this is CardioCare. It's in area 11 Gariki. So terminologies. Before now, there have been terms like malignant hypertension, accelerated hypertension. However, those terms have been replaced by hypertensive urgency and emergency. The times when we used to call it malignant hypertension has typically gone, including the times when we used to call hypertensive crisis. Even the title of this topic already is somehow flawed because that term has been replaced with two relatively distinct entities, urgency and emergency. The difference between hypertensive urgency and emergency is the absence or presence of acute end organ damage. That is end organ damage that is happening concurrently or at the time or happening new because of that high blood pressure at that time. Okay, so that's what determines hypertensive urgency or emergency. When there is presence of acute end organ damage, then we call it a hypertensive emergency. And when there is no end organ damage ongoing, then we call it an urgency. So it's defined essentially, urgency is defined by a diastolic blood pressure greater than 110 millimeters of mercury without any signs of acute end organ damage, which means that it takes time to exclude. So hypertensive urgency is kind of a diagnosis of exclusion. You must have excluded certain risk factors happening concurrently with that elevated blood pressure. So just before I started, a patient just texted me, his blood pressure was 160 over 120. Of course, I couldn't answer to him. I just told him, please do this before I could go ahead. But that defines a hypertensive urgency to an extent. Now, if I see the patient, I will now make sure that there is no end organ damage. Then I can truly say that this is a hypertensive urgency. However, if I cannot, then I will be able to, if I see any end organ damage, I will now call it a hypertensive, I will now call it a hypertensive emergency. Okay. So, however, when there's hypertensive emergency, just like I said, when there's end organ damage, then there's hypertensive emergency. There is no specific blood pressure that establishes a diagnosis of hypertensive emergency. Somebody can call you and say, my blood pressure is 160 over 100. And you say, no, it's not hypertensive emergency. No, that's wrong. Hypertensive emergency is not essentially defined by the level of blood pressure. Rather, it is defined by the presence of ongoing or progressive acute target end organ damage. So some people can be having a hypertensive emergency as low as 160, 100. So they come with acute left ventricular failure, they come with acute coronary syndrome, with a stroke, they are having hypertensive emergency. And you cannot say that because there are not that many people there are not many, it's not that high. That is why you cannot call it an emergency. Okay, I see that everybody is on now, a lot of people are on now. For those that cannot get on, please remember that we are also broadcasting on Facebook, CardioCare.center. Okay, so I'll continue. So why is it important to differentiate? Is it just one of those things? When I was a medical student, we say internal medicine, cardiologists, they are always just talking. They are just moving stuff every day. But that's not the case. There's a reason why we must differentiate urgency from emergency. Why? The reason is that in an one of them, let me say it's one of them so that we can go forward. One of them needs immediate parenteral blood pressure lowering in a monitored setting in order to minimize damage. And that is hypertensive emergency. There's already damage going on. You need to do something immediately, IV. Now, if you have an urgency and you give IV drugs, you will cause more harm than good. If you have an urgency and you give rapidly lowering drugs, you will likely cause more harm than good. And so that is why we say hypertensive, you must be able to differentiate between both of them. Any delay in addressing urgency or emergency can possibly lead to irreversible organ dysfunction. So what are the conditions that characterize hypertensive emergency? Number one is hypertensive encephalopathy, in which case there's obtundation, there's change of sensorium, but very importantly, there is no focal neurologic deficit. Very important. Number two, we have stroke, which can be ischemic or hemorrhagic. We can have an aortic dissection, which simply means that the inner lining of the aorta is peeled off. Okay, so that's what aortic dissection means, and that can happen with very high blood pressure. In fact, in aortic dissection, blood pressure may not even be that high. Blood pressure could just be as high as 130/90. In which case, because you have found ongoing aortic dissection, you must treat as a hypertensive emergency. Then we have myocardial ischemia. Now, very important is the one I'm going to talk about now, which is post-operative bleeding. A patient soon after surgery starts showing signs of bleeding at operation sites, reduction in pulse, and the blood pressure is very high. That also has to be taken like as a hypertensive emergency because it is causing damage and that must be addressed immediately. Then we have eye signs, renal failure, and eclampsia. Now, before we go far, I must quickly say about what they call pseudo-emergencies. In pseudo-emergencies, the rise in blood pressure is due to a physiologic trigger that causes a massive sympathetic or catecholamine surge. Maybe the patient is having a lot of pain, severe pain, and then you take the blood pressure, then you are having that, you need to be careful. Patients with hypoglycemia, anxiety, severe anxiety, post-ictal state, they've had a seizure just shortly after. Patients with hypoglycemia or hypoxia. So these scenarios must be differentiated from a true hypertensive crisis. And the treatment for a pseudo-emergency is not going to attack the blood pressure. You must deal with the underlying cause. So if I have a patient coming out of a surgery, maybe a CS, and is having a severe elevated blood pressure and post-operative bleeding, just like we talked about in the previous slide, before we start, say, this is hypertensive emergency, let's go and get IV dimetrodol, or let's get IV nitroprusside. No, you must also take care of pain. Sometimes you take care of pain and the blood pressure comes down, in which case what you actually had was a pseudo-emergency. So that has to be looked at. So why did I have to wait for people to join? Because of pathophysiology. If you don't understand the pathophysiology of hypertensive emergencies, then hypertensive crisis, urgency and emergencies, then you may never really know how to treat. This is the meat. If you miss anything else, don't miss this. And if you have any questions on the pathophysiology, make sure you be sure to ask them in the Q&A. So there's a button called Q&A on the Zoom, which you can ask, and also on Facebook, which you can ask. I have somebody checking Facebook for me. So if you have questions and you're watching on Facebook, you can also ask in the comment section and we'll answer them when we get to time for questions. Okay, so why is this pathophysiology important? Now, we have to start from blood pressure. Blood pressure is cardiac output times peripheral resistance. What does that mean? It means that blood going through a pipe, like a pipe of water, the resistance on the pipe. So if you press down a pipe like you want to wash a car, the pressure shooting out is higher. That means you have increased the resistance. Now, if you also increase the heart rate or the volume, you also increase the pressure in that pipe. That's how blood pressure comes. And it's very important. We'll talk about that going forward. Now, there are several other things that affect it, humoral and other things. One of the main things that happen in a hypertensive crisis, urgency and emergency, is a breakdown of the autoregulatory function that happens, and that increases the systemic resistance, and I will explain that going further. So like I said here, you have the blood pressure, which is cardiac output and total peripheral resistance. Hormones and other things, adrenergic factors, all affect peripheral resistance. Heart rate affects, and blood volume affects the cardiac output. Okay, so blood pressure is brought up by this. The next thing is that blood flow is affected by blood pressure divided by resistance. So blood flow is blood pressure divided by resistance. How does that help us? It means that if you have a high blood pressure, like you have in hypertensive emergency or crisis, the resistance has to go up to maintain the blood pressure. So for the blood flow to remain constant, so if we have 100 mils per minute to a kidney or something else, for that blood flow to remain constant, what must happen? The pressure, if the resistance goes up, pressure must go up. If pressure goes up, resistance must go up. So it's, blood flow is inversely proportional to resistance. The higher the resistance, the lower the pressure. So when you have a high pressure, resistance must reduce. Now, sometimes that resistance is also high, and that is why it's important for us to know. So in a normal individual, and you can see the normotensive curve and the hypertensive curve, for a certain mean arterial pressure, it doesn't matter how the blood pressure changes. The mean arterial blood pressure, cerebral blood flow remains the same. So the mean arterial blood pressure of 50, to almost 150, the blood flow remains the same. And how does that happen? It happens through this formula. So what the body simply does to maintain blood pressure and maintain blood flow to the organ at the same rate is to change its resistance. So as blood pressure is rising, resistance will be reducing. And as blood pressure is falling, resistance will be increasing, all to try and maintain blood flow at the same rate. In a hypertensive, however, what happens? Because of that sustained blood pressure, the smooth muscle around the arterioles hypertrophies. That hypertrophy is protective so that it can be able to alter the pressure and the resistance and the amount of blood flow going to the end organ. So because of that very reason, if you bring down that blood pressure too fast, the smooth muscles will not relax as fast as you blow down that blood pressure. And if it doesn't, then you create ischemia because the resistance will still be high, the blood pressure has fallen, and the blood flow will also fall. And this is central to management. If you don't understand this, I will probably go over it again and again during this presentation to allow everybody to understand this. This is central. So you have a patient, like we put in our ad, you have a patient coming to you during COVID. Doctor, my blood pressure, you check it 210 over 160. What do you do? Okay, what do you do? Somebody says, doc, quickly, sublingual nifedipine. No. Number one, sublingual nifedipine should never be used. Never, under any circumstance, in any setting. So at least for those watching, you should know that. Never, ever, ever, ever. How many ever have I said? Maybe some extra. Should sublingual nifedipine be used in an acute elevated blood pressure? Why? The absorption is erratic, and so the blood pressure affectation is erratic. It can slam blood pressure from that 210 to 100 in 1 second before going back up. Okay, and that can be deleterious. And so what happens when it slams that fast? The smooth muscles, which were controlling the autoregulatory mechanisms here, do not change their resistance fast enough. And what happens? Blood flow to that end organ is drastically reduced, and you have ischemia. So most times when that happens, the next thing that the patient develops a stroke, the patient develops a problem, renal failure. So people think that, oh, it was the blood pressure that caused it. No, it was the doctor's therapy that actually caused it because the person did not understand this single slide. Okay, so please, if you have questions, like I've said, please put in the Q&A, so some of them I'll just answer them as I'm going on ahead. So, like I've already explained all of this in the explanation. So, what other things happen? The high blood pressure, the kidneys perceive it as very high blood flow. and that reduces, increases the contractility of the arterioles entering the kidney, okay, the afferent arterioles. That now stimulates aldosterone. Aldosterone stimulates sodium retention and potassium excretion. This now maintains excess volume, and that leads to uncontrolled blood pressure. The end organ damage that happens also releases inflammatory markers, tumor necrosis factor alpha, interleukin 1, interleukin 6, and that causes endovascular injury. The endovascular injury goes on to further cause problems with the arterioles, and this forms almost a vicious cycle. Okay, so that's the explanation. So actually, hypertensive episodes can also occur because of what I've said, that is changes in the kidneys can decrease, the kidneys sensing that there's reduced blood flow can cause that massive increase, or sometimes it can occur from pre-eclampsia or eclampsia, in which case it may not have come from the kidneys, it came from substances, typically from the placenta and vasoreactivity, so we'll not talk, that's a topic for another day, or from fake chromocytoma where there's a surge of catecholamines, or from primary aldosteronism, glucocorticoid excess, or from strokes, tumors, and all that, in which case the body is trying to respond, and that can cause the massive blood pressure elevation. So about 30 to 40% of patients with a hypertensive crisis, that's urgency or emergency, have an identifiable cause, and so you need to look for it. You need to evaluate it. Some patients are coming with hypertension for the very first time, and that the hypertensive crisis may be the first time you are picking that. There are many times we've gone for outreaches as CardioCare hospital to places, and somebody is joking with everybody and says, for sure, let me just check my blood pressure. And we see 210, 160, 210, 150, and the person says, I have never been told to do it to be hypertensive. We check it again, we change feed, and we are sure that this is a hypertensive crisis happening, and we just found it, on the spot without any symptom. So it's not always for it to be symptomatic. We typically hate to hear when patients are said to have stopped the hypertensive because a doctor or the other told them, you know what, just take this drug for 2 weeks. In most cases, more often than not, antihypertensive need to be taken for a long time. So sometimes precipitants, commonly could be hypertensive and may have other precipitants. So what are the actual conditions that precipitate a hypertensive crisis? The patient is hypertensive ab initio, and now hypertensive crisis is precipitated. So number one is essential hypertension. From normal, the main thing is that the patient is not controlled. This is the first time we are seeing the patient, and the patient is not. So somebody asked, can catecholamine secreting tumors cause pseudo emergency? Of course not. No, it cannot be. It's not a pseudo emergency. It's actually an emergency. It's one of the reasons why. Okay. So just wait a minute. You get the answer. Babatunde or Motesho. You get the answer about when you use parenteral or not. Okay, so you will get that answer as well shortly. Okay, great. So I've checked all the questions. Okay, so what was I saying? Other conditions. Sometimes his patient has been taking their drugs and they stop, just like the patient I told you that just sent me a message now. The patient was taking the drug and said, it's affecting their manhood, it's affecting they're having some headache, they are feeling one kind. They went somewhere and they bathed with a particular water and they told them to drink aloe vera and they stopped the antihypertensive suddenly. That sometimes can precipitate the hypertensive crisis. They stop the antihypertensive suddenly, the kidney response, like we said in pathophysiology, it goes up, autoregulation is lost, and the blood pressure keeps on going and going and going because the body's ability to control blood pressure is now lost at that point in time. Then kidney diseases, in stroke, then drugs, including recreational drugs. So when you see a hypertensive crisis, you should also look into the pupils or take a good history. Sometimes patients are taking cocaine or taking something, and in this time, sometimes that's quite important, especially in Abuja where CardioCare is located. We also have scleroderma, and that is typically part of scleroderma crisis. Preeclampsia, as we all know in O&G, obstructive sleep apnea, failed chromocytoma, all of that could be part of the, could be one of the etiologies. Now, there are other things that's risk factors for progression to hypertensive crisis. After you have all these precipitating factors, what are the things that make people likely progress? Number one, whether they are male. Number two, they are black. So I see everything, black males are at the bad end of all of this thing. Black, poor males that smoke. Black. So I see some patient, I say, you are black, you are a man, and you are poor. Triple already. So those are things that are likely to make a progression likely. And then sometimes hypertensive crisis is said to peak around 40 to 50 years. However, in Nigeria, it is known that most of the cardiovascular things that happen among Nigerian patients tend to happen at a lower age than what has been reported in the Caucasians. And most of the authors in Nigeria on the authorities on hypertension, from Dr. Oga, Professor in Akinkugbe in Ibadan, will tell you that hypertensive diseases are found typically in younger individuals in Nigeria. So I told you about drugs, cocaine, oral contraceptives. One very important one that a doctor must look out for is cold remedies. Is the patient taking drugs for a catarrh, a cold? And in time of COVID now, this is one of the things that can happen. Patient is feeling cold, they are afraid to go, they are having running nose, they are afraid to come to the hospital, they buy over-the-counter drugs, they are not on their medications, and boom, blood pressure goes up. And sometimes clonidine withdrawal, people that have been chronically using benzodiazepines. So what kind of history are you going to take from that patient as a doctor? The patient is now with you. You are supposed to do the necessary things, okay, as a responsible doctor. Okay, sorry about the sound. So you're supposed to check the duration of the blood pressure. Sometimes the duration, somebody has had 170, 120. Yes, it qualifies for hypertension urgency. But sometimes you find that, oh God, it has always been like that. I had a patient, 190, 150, and she said she has had that for the past 2 months straight. In fact, by the time we're getting to 170, 120 in that patient, she started having signs of hypertension. That is how her body had gotten used to that very high blood pressure over a long time. So it's very important that what you are seeing, you need to be sure that whether it's acute or it has been there for a while. Recreational drugs, whether they've taken anything recently, and then some primary etiologies. Your history should also focus on the organs that you are looking at. So you must check for chest pain, shortness of breath. You must check for headaches, confusion, lethargy, altered mental status, nausea and vomiting. So you have a patient nausea and vomiting with an elevated blood pressure. It is not something to be taken lightly. You should already be thinking that there is some ongoing emergency in the brain and you may need to act urgently. Reduction in blood, in urine outputs or proteinuria may also be, or hematuria may also be a sign. Sometimes patients have blood vision, which is but a lot of patients are known to wait for symptoms. They don't take a break of. No, that is not our recommendation. Our recommendation is that the patient should continue that medication rather than wait for any symptom, because the symptoms may be misleading. So when you're examining, your primary reason for examination in a hypertensive emergency is to determine whether end organ damage is present. Remember, I told you it is critical to be able to differentiate between urgency and emergency. So for those that have joined us later, I will just recap. Hypertensive urgency is a severe elevation of blood pressure. Typically, diastolic blood pressure greater than 110 or 120 without end organ damage. And an emergency is the one that has end organ damage. The reason why we must differentiate them clearly is that one needs acute intravenous therapy in an ICU setting. Another can be managed over days with oral medication. Apply the treatment, you can actually do more harm than good. So that's why when you are doing your examination, one of the first things you are trying to find out is there end organ damage present? And so from your history, you start that, check for GFP. The patient in heart failure, is the patient having other things? They are an S3 or S4. You have to check the blood pressure sometimes in both upper and lower extremities. So you need to have a tight cuff. We have that in our center, of course, but a lot of times you need to have that even when you are practicing. You need to have a tight cuff. And if you cannot at least get that, you should at least have blood pressure taken in 2 arms. Your severe hypertension can only be confirmed after 2 blood pressures. So don't take one blood pressure measurement and rush and start giving medication. Take it at least 2 blood pressure measurements separated by 15 to 30 minutes apart. And then you check for pulses, for bruit. Very important to check for renal bruit. We saw a patient about 3 years ago, severe blood pressure has been treated everywhere, and by the time we just put your stethoscope. So how do you measure check for renal bruit? Use the bell of your stethoscope. That's when you turn your stethoscope the other way around. And listen 2 centimeters lateral and superior to the umbilicus. So get to the umbilicus, 2 centimeters lateral and superior. That is the point you should be listening for your renal bruit. Put the bell of your stethoscope, turn it the other way, and listen carefully. You could hear it, and it will be coinciding with the pulse. So on both sides, we heard it very well. We went on to confirm it via a renal Doppler, and that is quite critical because it changes the way. And that patient is potentially has a curable cause for hypertension. Okay, so you should check for renal artery bruit, like I've explained. You should do a neurological exam. It is critical. It is almost criminal not to do a neurological examination when somebody has that. And how do you do that? Very simple. Check the mental status. Is he confused? Does he know where he is? Does he know what's happening? Or number 2, ask the person to raise both hands up like this, as if they are praying to God. Okay, this is Ramadan time, so as if they are praying to God. I can see my screen. They raise both hands up, stretch out their hands, and check for a pronator drift. They close their eyes. Typically, if there's a weakness, one of the hands will start drifting away. That's what we call a pronator drift. So check for that. Check for facial deviation. Check for slurred speech. At the very least, you should do that. You should check power in all the limbs at the very least. And remember that we said that there is no level of blood pressure. You can't say that this blood pressure is too high, it must be an emergency. No. If blood pressure is too low, it's urgency. No. What differentiates it is the presence of end organ damage. So what are the pointers to hypertensive emergency? I'm listing 11 pointers towards hypertensive emergency. So if you're not sure, patient is having chest pain without high blood pressure, shortness of breath, headache, blood vision. If there are signs of altered mental status, focal neurologic deficit like I talked about, limb weakness, pronator drift, facial deviation, things like that. If there are eye signs, you use your fundoscope, you look, your thermoscope, you look. If there are crackles in the lungs, if there's differential blood pressure in both arms, if there's an S3 gallop, if there are pulse deficits, these are pointers that what you are dealing with hypertensive emergency, and you need to act accordingly. So what you do in the lab? The first thing is that I need to state is that never stop your treatment because you are waiting for lab results. Don't say, okay, you are waiting for lab results to know what to do. No, you must start. If you think it's an emergency, you must start treatment immediately in the ICU, preferably while waiting. I know now ICU has been moved towards COVID and all that, but you must start it in the ICU, preferably while waiting for whatever results. Full blood count is quite important, and it's quite important to also have a blood film. When there's anemia and schistocytes, that will likely point towards microangiopathic hemolytic anemia. Okay, I can see questions are rising. I'll get to answer all of them. Okay, shortly, just hold it, I'll get to them. And then if you have hypokalemia, it can give you a clue to what may be causing the hypertension. ERU is very important. EUCR is quite important to pick any renal dysfunction. So patient has a high blood pressure. This is not the time to say, maybe they have money, maybe they don't have money, maybe you should do. No. Patient with that severe elevation of blood pressure, especially first time diagnosis, you need to do this. You need to do an ECG, and you need to be able to read an ECG. If you were at our last cardiovascular symposium organized by the same CardioCare hospital, you will have learned to an extent how to read an ECG and to identify these kind of problems. Then a chest X-ray should be performed in patients who complain of shortness of breath and or chest pain. Very, very important that you do a chest X-ray, because the widening metacinome might represent our chest pain, central chest pain, a widening mediastinum, and you check the blood pressure in both arms. and there's a difference in the blood pressure in both arms by 30/15, some people lower it to 20/10 in both arms, then you should consider very strongly an aortic dissection. Then, of course, drug screening. There are a lot of urinary kits to just do a dipstick and check whether there's any illicit drug use. Okay, sometimes, if it is possible in your center, you may want to, if the patient is an urgency, not an emergency, meaning that there's no ongoing end organ damage, obtain a sample first for renin and aldosterone levels, and take your serum and urine for metanephrine analysis. This helps you to retrospectively analyze for secondary causes of hypertension. Because when you use drugs initially, it changes the results of the renin, the aldosterone, and metanephrine. So if you think that a patient may be having pheochromocytoma or this with that height of blood pressure, take the sample so that you can analyze it, and the urine, so you can analyze it before you start your medication. But if you cannot do that, don't wait. Don't say you are waiting to take sample, that's why you not give no. So just a note for that. Okay, so we'll go to treatment now and how we treat. Before we go into treatment, let me look at questions that may have come up. Good afternoon, sir. Mean arterial blood pressure greater than 145 millimeters of mercury and is hypertensive urgency. Do we use parenteral or oral antihypertensive medications? So we'll answer that as we go to treatment. Is antihypertensive taken for life? And in the event of BP coming down to 90/60, should the dose be halved or stopped? So antihypertensive treatment most times is taken for life, most times. But however, if patient is doing some other concurrent things, they are engaging in good lifestyle therapy, there are occasions where you may have to stop the antihypertensives. Typically, if you're having hypertension, either you're having actual hypertension or the patient is having symptoms of hypertension, that they're having dizziness, they are feeling lightheaded, you typically have to relax your antihypertensive therapy, which might be removing some drugs, reducing doses, or even stopping it. But then if you are going to stop it, you must make sure that you keep on following up that kind of patient, or best just keep it to a very low dose of a mild agent. Okay, what you have to say about people who have a blood pressure above the standard 120/80, but this is their normal BP and they're not on antihypertensives. How to differentiate them from general population in clinical practice? So when you see a patient with an elevated blood pressure, so in clinical practice, 130/80 and above will be considered, 130/85, like the new GNC guideline, will be considered to be pre-hypertensive. So if somebody is having 120, so there's a diagnosis in ICD which we typically use, which is called elevated blood pressure without diagnosis of hypertension. And patients will typically fall into that category, or pre-hypertension. They are above 130, but they are not at 140. Those patients typically should start lifestyle therapy. Okay, now another approach to that is to do an ambulatory blood pressure monitor. Sometimes you are seeing patients, they are having 130/80 at rest in your office. If you do a 24-hour blood pressure monitor, which we typically do in our center, you could find at times during the day the blood pressure is as high as 190. And so those kind of patients you may need to treat. So you may not be able to take a full decision without that. Number 3 is that when you do some tests, you may be able to find out just that end organ damage ongoing, and you may need to stop. You may need to start that. Okay, and I will keep the many questions for the end as we continue. Okay, so how do we treat hypertensive crisis? And I said that the treatment must vary because of the kinds of things the kind of the pathophysiology which we talked about and we taught. Okay, so patients with a stroke and you give aggressive blood pressure, especially ischemic stroke, and you do aggressive blood pressure, typically have poorer outcomes. They have worse, they die more, they have worse residual neurologic deficits. So that is why it is not very right for you to have a patient come with a stroke, blood pressure 210/180, and you rush and you start giving IV medications. No. Typically, if you do very aggressive blood pressure, because that is an emergency. It's an emergency, all right, but the approach to treatment of the blood pressure must be measured, unlike other emergencies where you are trying to bring the thing down. And so the golden rule is that treat the patient, not the numbers. So sometimes somebody will call me and say, I have this patient. Sometimes if you don't if you just say, I have a patient 180, 130, what should I do? No. You have to look at all these other things I've talked about. Take the history, look at the examination, and treat the patient, because things will differ from one patient to the other. And very important is first, do no harm. Sometimes people have given antihypertensives that have done harm, more harm than good, and that is quite unfortunate. So it's important for the clinician to remember that do no harm when treating this. So it's important that you do no harm when you are treating patients. I put this very big, please, no sublingual nifedipine. Please, no sublingual nifedipine. Or any medication you are putting under the tongue. The blood pressure, nurse, bring it. No. You have attended this webinar today from CardioCare Hospital, and we are telling you, do not do it. It causes more harm than good. Sometimes you get away with it, but other times it causes ischemia. Remember what we talked about. The body is already used to that high pressure. The arterioles have hypertrophied. The smooth muscles around the arterioles have hypertrophied. You put sublingual nifedipine, it has an erratic blood pressure approach. It slammed the blood pressure so low, but the smooth muscles were already, trying to keep the excess pressure away from the end organ. Now that blood pressure drops, the blood will not get to the end organ, and you typically will cause a stroke, you will cause renal failure, you will cause something. Okay, so please, no sublingual. And IV-adrenaline, there are specific places when you use IV-adrenaline. You must be very, very careful with IV-adrenaline. Okay, and I will explain why as we go forward. So I'm sure that this will be much benefit to your patients going forward. I'm sure all of you, your patients will testify about this, and you'll be likely very happy with this. So what is our treatment? What's the aim of our treatment? We want to reduce the mean arterial pressure by no more than 10%. This is our general rules. I'll go to specifics. 10% to 25% of the blood pressure it is in the first hour. So you have mean arterial pressure of 160. Your aim is to, in the first hour, is to get it to reduce 16 milliliters of mercury of that, or not more than 40. So 16 to 40 if you have 1 mean arterial pressure. So a goal blood pressure of 160 over 90 in the first 8 hours is typically what you are looking for. And then later normalization of the blood pressure over 8 to 24 hours. And this is why all those approaches may not be very best, especially in an urgency. Okay, so the treatment of hypertensive urgency, and most of this I'm talking about is for urgency. Sorry, this is for urgency. Treatment for urgency is usually immediate. It warrants close follow-up. So blood pressure may be alarming to the patient. Patient is having that very high pressure. They are shaking. They say, "Doc, I'm dying." For one patient say, in fact, he's going to fly to Dubai that night, where Corona has come now. Everybody is sitting there in Nigeria. So patient may be alarming, but you need to be cautious. You need to be cautious. The patient is having a blood pressure that high, 190 over 150, and it has been like that over a long time. And importantly, remember urgency, there is no end organ damage. So in the absence of that end organ damage, then you go up, you go forward and say, okay, fine. We're going to reduce the blood pressure, but you need to do it gradually. Typically, you are trying to reduce blood pressure over days to weeks. In the first hour, first 8 hours, not more than 10 to 25% within the first 8 hours. So don't go and give sublingual drug and tell the patient to wait, let us see, no, and tell the patient that you brought it down and they're happy about it. No, that's not correct. So this rapid decrease in blood pressure usually causes symptomatic hypotension. Patients start feeling dizzy. We've heard of patients that collapsed after a doctor gave a drug to bring down blood pressure, So after ruling out organ damage is to treat according to the guidelines of this. So sometimes you might want to use a rapid onset oral agent, not sublingual, oral. Okay, and then you typically plan to use them for a short-term duration, 24 to 48 hours, and then you can continue. Patients typically should be monitored in a hospital if you can, but if you don't have to admit some patients. Sometimes you can, if you are sure you can follow that patient over a short time, they come in a day or in 2 days' time, you give them something that brings it down gradually. So they are 180, 150 or whatever today, no end organ damage. You are very sure. You have given them their medications to start. not all of them. You give them maybe nifedipine, just a few drugs they have given them. They come back tomorrow, it's 160, 110. You are doing a good job. That's exactly what you are aiming for. You are just bringing it gradually. So that in 24 hours, you have brought it down just a little, and then you gradually bring it down. That way, the smooth muscles and the arterial supply those organs have time to adjust to the new blood pressure before you now continue what you are doing. So this is essentially what I've said. It's very important that patient education, we cannot emphasize this enough. You should not just give them the drugs, they get better, they go home, and then they go and stop their drugs, only to come and die later. You have to take some time to educate the patient. Sometimes when I have a very busy OPD, the CardioCare hospital, those kind of patients, I will tell them to wait. We take care of the acute patient, then we call them in, and I take my time to explain to them. Talk about weight loss, talk about salt, talk about the fact that most times blood pressure medication has to be taken for a lifetime. Tell them the real truth about this thing. So that patient will just take the drug and stop is unlikely to be true and unlikely to give out to bring the worst outcomes. So you have a lot of patients that have started medications only to come back with stroke because they stopped the drugs after a time, or they were never told that they need to take the medication for a long time. So for emergencies, it always warrants hospitalization, and usually in the ICU. So if you don't have an ICU, you should at least have a monitored ward. That's what I call a monitored ward. You have a ward in your hospital where you have one nurse to one patient, maybe with a monitor, or that can be checking the blood pressure every maybe 5 minutes or 10 minutes. Okay, that is the nearest. But ideally, you do what you can and maybe refer to a hospital with an ICU. So what we typically do is that we admit the patient into our ICU. We typically set up an intra-arterial line. So the arterial line that we set up is for ongoing titration. And very importantly, at this point in time, why do we say ICU for emergencies? Is that you want to monitor not the blood pressure from outside, but the blood pressure from inside, the actual invasive blood pressure. So I'll show you a picture of one of the gadgets that we use. We puncture the arterial line, we put in the cannula, and we connect it to a transducer, an invasive blood pressure transducer, to the monitor. So the monitor is telling you the actual blood pressure in the artery. So it's measuring it like an actual manometer, and it's changing per second because every time you had this, it's changing. So that way you can see what is happening. You don't have to wait for the thing to pump and come down. So you really need that when you are going to tackle this kind of high blood pressure. That's the ideal way. But if you don't have that, do what you can till you can refer to an appropriate center. Okay, and the purpose of treatment of emergencies is to preserve organ function. And the organs typically affected are the brain, the kidney, and the heart. Those are the typical organs affected in the So goal-directed therapy is very important. Be careful also, even in an emergency, we still don't want a crash of blood pressure because patients can die. Those same things we talked about, try and reduce by 10-25% the first hour is what you are aiming at. Yes, blood pressure is 210, 150, 210, 190. Okay? There was one time when I was in residency training, maybe about 10 years ago or thereabout, a patient came in and the blood pressure, the fig could not measure the upper limit of the blood pressure. As in, we pumped and pumped and pumped, it was above 300. Before we could turn around to get a glove or do anything, the patient just seized and died. Okay? But that patient was coming from somewhere, and nobody did anything. Okay, so even at that level, two whatever, you still want to bring it down gradually. You don't want to bring it and slam it down. So you take it, bring it down gradually with your continual blood pressure monitoring. So there are exceptions of how to manage it, which I will talk about this. So this is a HDU, a high dependency unit, even though there's a monitor there. And the patient monitors you are seeing here, this is from CardioCare. The patient monitors you are seeing all have an invasive blood pressure monitoring kit. Okay, so if you look on the right of your screen, you will see what the transducer looks like. It looks like a given set, only that at this end, you can see this end, it looks like a telephone cable that is connected. So when you pass the line, you connect what is like a three-way cork to that IV line going into the artery. And then part of that cork is attached to a manifold, and that manifold is connected to this is transducer, and connected to the monitor. So on the monitor now, you will now be seeing the invasive blood pressure going on. If we have enough time, I will show you some more pictures of how it is done. But generally, you have to put the patient here. You are monitoring. A nurse, a doctor is seated in that place. You need to have 1-to-1 ratio of caregiver to patient. Okay, great. So I will now talk about specific conditions. So this is CardioCare, and this is our ADU. So one of the things is also that the flooring is also particularly, and then you have a ventilator in case you have to intubate a patient in. So hypertensive encephalopathy essentially is severe hypertension, but is indicated, this diagnosis is made when there's a change in mental status. Typically, it can be very difficult to differentiate encephalopathy from stroke. So the patient is not unconscious, is semi-conscious, and is having blood pressure very high. That is a hypertensive encephalopathy. But you must be very careful to exclude that there is no focal neurologic deficit. That typically is what helps you to differentiate. Or you need to do a CT scan. Okay, a cranial CT is almost always invariable when you are doing that. So what happens in the hypertensive encephalopathy? The blood pressure gets too high. Remember that our diagram, it goes beyond the level in which cerebral autoregulation can occur, can be managed. And the body's ability to adjust pressure and blood flow to the brain is lost all of a sudden. A lot of blood gets, that pressure gets to the actual endothelium of the vessels, and that causes hyperperfusion. So all that pressure is transmitted to the brain, and that leads to cerebral edema and very small minute hemorrhages that are seen. Okay, so in cases of, and then patients typically could have seizures. So it's similar to a stroke. You need to have a proper exam and a CT scan to be able to rule it out. There are a lot of other causes. Theoretically, eclampsia is a form of hypertensive encephalopathy, theoretically. So what essentially they are having an altered sensorium, they're having seizures, they have a severe elevated blood pressure, they're also having some form of cerebral edema. So to some extent, you are treating it almost similarly. So, but again, I remind you, caution will be taken not to reduce it too swiftly because of that same pathophysiology we talked about. If you crash that blood pressure, the patient goes into has a stroke and dies or worsens or never comes out of that unconsciousness. So you still have to follow it and bring it down gradually. Whenever you hear somebody successfully, somebody written a referral letter and say, I successfully brought down the blood pressure from 200 or something, whenever you hear that kind of thing, it's typically not good. Okay? And so if the patient's neurological function worsens while you are treating, you need to stop. You probably are treating too fast. And sometimes allow the blood pressure to rise a little more, allow it for some time, and gradually and readjust your way of breathing. So the preferred antihypertensives for hypertensive encephalopathy are labetalol, nicardipine, and phenoldopa. We'll talk about that. There are drugs that you should not use in this situation. One is Aldomet. So by the time of having this kind of situation, Aldomet is perhaps not a very good choice if you can help it. Okay, why? Aldomet and clonidine and reserpine all cause, reserpine is typically part of other central agents are part of the old drug called Brinedine. So you used to have reserpine. Reserpine is almost out of the market, at least in the Nigerian market, but it's still there. So it clouds sensorium, it may even worsen the unconsciousness and the altered sensorium. And sometimes even though you are winning, you may not be able to tell. So the patient is still very sick. Now hydralazine, this is why I don't like hydralazine. Okay? Hydralazine should not be used. And why is hydralazine, you should not use hydralazine in this kind of situation? Why? Because it raises intracranial pressure. It's very important. Hydralazine raises intracranial pressure, and because of that, if you use it in a hypertensive encephalopathy, you may increase the intracranial pressure to the detriment of the patient. There are certain instances under which hydralazine may be used in encephalopathy, but that's beyond the scope of discussion and must be done with a specialist and in an ICU setting. But long and short, hydralazine, Aldomet, no, because of the things I've talked about. Even though hydralazine is very readily available and it's quite cheap, you should be very cautious about using it. So our preferred is nicardipine, sometimes not very easy to find, or labetalol are the preferred ones, or phenoldopa. So another thing that can happen is myocardial infarction. So sometimes ischemia can happen. The blood pressure is so high, the increased workload on the heart, renin-angiotensin system is activated, just like we talked about, And then there's now reduction in blood flow to the heart, either because a plaque ruptures or because the heart is overworking beyond its supply. So what happens, antihypertensives are recommended together with reperfusion therapy. So typically you should plan for your thrombolysis and angioplasty, which can be done immediately. So you should, as a doctor, you should know where the cath labs are near you. So CardioCare has a cath lab. I think for most of the North, that's the only indigenous cath lab. So you should know where the cath labs are near you. The patient having a very high blood pressure and having a heart attack, you should get them to a cath lab after you have controlled the blood pressure. So even thrombolysis should be used cautiously, but after you have controlled the blood pressure. Okay, the reason you are doing is that you want to preserve the heart as much as possible. If you don't do it fast enough, the heart muscle dies and the patient has heart failure that has a very high mortality rate. What are the agents that we typically like to use for this? Nitroglycerin. IV nitroglycerin is the treatment of in this case, or beta blockers. And sometimes you do or beta blockers. Typically, you use beta blockers in a patient with myocardial ischemia anyways. So now you add that and then you give your IV nitroglycerin. Nitroglycerin will cause both venous and vasodilatation to an extent and reduce the afterload and the preload of the heart. So the heart doesn't have to work as much pumping against a high pressure. The pressure that the heart is pumping brings it down. The beta blockers reduce the output of the heart and the contractility of the heart, allows the heart to relax a little to allow blood flow to come in. Okay, so typically you gradually reduce the systolic blood pressure until symptoms subside. And you typically should aim, in this case, for diastolic blood pressure of less than 100 millimeters of mercury. Okay, typically morphine, remember that it's monas as and oxygen are typically used. Morphine causes venous dilatation, reduces the anxiety of the patient, helps the patient to be more comfortable, and then you give oxygen as well in this kind of case to reduce. Don't give heparin when blood pressure is uncontrolled. Don't also give aspirin when blood pressure is uncontrolled. So I've seen patients, their blood pressure is very high and give them antihypertensive and add aspirin or clopidogrel. No, don't do that as much as possible, except there's a reason. In myocardial ischemia, however, you may consider still giving because the benefit might outweigh the risk. But in that kind of situation, please get the input of a specialist. So I cannot cover that one in this, and every patient differs in this one. So get the input of a specialist to get that done properly. Okay, but when you're starting heparin, so sometimes you can do complete heparin infusion or Clexane while you're treating myocardial ischemia. But when the blood pressure is very high, you need to be cautious or not start at all because of the risk of intracerebral bleeding. Okay. Okay, great. We have a lot of questions, so we'll come to them. So this is what the cath lab looks like. Essentially, it's an advanced form of a C-arm. So the patient is brought in an emergency. We can't control the blood pressure in the ICU or the ATU. We bring the patient into our cath lab, and then while the blood pressure is better controlled, with the patient still awake, what we do is that through the femoral artery or through the radial artery, the same arterial, we put the arterial line in, not the same one, a separate one, and then we pass the wires in till we get to the blood vessels, and then we open up and open up. We do the angioplasty immediately, emergency. So we do that 24 hours irrespective of that. This is done without open surgery. Okay, so at that same city we do it, and then you take care of it while you are controlling the blood pressure. You need to do both. You need to control the blood pressure, and you need to get the arteries open as quick as possible if you can help it. And at least Abuja is 90 minutes for most of Nigeria via air, maybe after Corona. So you need to do both, otherwise mobility and mortality can be quite high. Acute left ventricular failure treatments. So this is sometimes called flash pulmonary edema. So I'm giving you the different conditions and how you have to manage the hypertensive emergency, and that is different to some extent. So we talked about hypertensive encephalopathy, and we talked about the drugs you should use and drugs you should not use. We have now talked about myocardial ischemia. We talked about the drugs that are more. Which ones did we say? You remember the drugs that we say are the best for myocardial ischemia infarction? Patients having myocardial infarction. Patients also having chest pain, but you did an ECG now. Are you able to differentiate for aortic dissection? What drug did we say? I think we said yes. Good. Okay, somebody has raised their hand. Okay, well, I'll just answer it for time. Suleiman, I'll answer it with time because of time. So we said we use nitroglycerin and beta blockers. Thank you very much. I'm happy that people are following us. Okay, so in acute ventricular failure, what is this? Essentially, this is also called an acute cardiogenic pulmonary edema. Some people call it flash pulmonary edema as well. So you have pulmonary edema and it's of cardiac origin. Okay, so these patients typically have diastolic dysfunction, they normally have long-standing hypertension, and they were fine yesterday. They were fine this morning. Maybe they fought with their, like one patient that I saw many years ago, the woman slapped her house help. Very angry, the house help. I don't know what the house help did. I think that broke the TV or something. Slapped the house help, and before you know it, started becoming breathless. And they said the house help was a witch. Rushed out to the hospital. Unfortunately, she didn't make it. You know, but you can imagine what will happen in that house. But what has happened essentially is that patient likely had hypertension and all that, had an acute rise in blood pressure, and had a cardiogenic pulmonary edema. So when she came, the whole lungs were flooded with fluids. Okay, so this is essentially what happens. So there is diastolic dysfunction, meaning that the heart is unable to relax properly. Therefore, the left ventricle starts to compensate for the rising blood pressure. So it's as if somebody is lifting weights. The heart is pumping against a very high pressure. So to compensate, it has to increase its muscles, otherwise it fails. So that increase in muscles reduces its ability to relax. Okay, once it starts doing that, then demand and supply of it now becomes problematic. So I'll go straight to try and explain. Slide, yes. So the acute elevated blood pressure leads to a mismatch of the afterload. So the heart is now not being able to cope with that very high blood pressure. Blood pressure of 160, 100, and it's shot up to 200 or over 140. Now that left ventricle is unable to match because it's shot up too fast. So there's a mismatch between the blood pressure and the ability of the heart to pump against it. So what happens with that? The end diastolic pressure suddenly rises. That pressure starts getting transmitted into the heart. Okay, so the heart is able to pump it back. It goes back to the elevates the pulmonary venous pressure. So it gets to the left ventricle, gets to the left atrium, pulmonary veins, and then gets back to the pulmonary capillaries. At this point, Starling's forces will happen. So there will be transcapillary leak, and that will cause pulmonary edema. I think that's straightforward. It's like a back pressure, the blood pressure and all the blood pressure are high, and the heart is not strong enough, doesn't have enough muscles because it happened too fast to control it. And because the heart is also has a diastolic dysfunction, it's also not pliable, so it cannot stretch enough to accommodate that extra pressure. So that pressure is transmitted back to the lung, and that extra pressure causes the capillaries to leak and causes pulmonary edema. Okay, so the preferred agent for treatment of this is nitroglycerin again, like I said, ACE inhibitors, morphine, and oxygen. Avoid hydralazine again. You can see why I don't like hydralazine again. Avoid hydralazine and clonidine. Why? It increases the workload on the heart. So that does not quite work out as well. So avoid it. So nitroglycerin is actually a preferred option. Furosemide, the patient is filled with lungs. Doctor, give me furosemide, 100 milligrams start. No, no. Okay, in a lot of cases, use of furosemide in acute ventricular failure and acute cardiogenic pulmonary edema, ACPE, may be deleterious in the long run. So you need to be careful about that. And why is that? So if the patient was euvolemic before, that is, the patient was not having any extra fluid, no pedal edema, everything was fine, and he just suddenly got the pulmonary edema. Chances are, if you use loop diuretics, you're going to cause more harm than good in the long run. So why? Why do we say that? The pulmonary edema in this case is just due to a shift of fluid, and it's not due to volume overload. So when you give the IV furosemide or the heavy dose of furosemide, you deplete the intravascular volume, not just the fluid in the lungs. So even though the furosemide also causes some venous dilatation, and even though you will still get some fluid out, because that venous dilatation will also help, not directly on the furosemide, in the long run, you are going to cause a shrinking of the intravascular space, which typically will cause a problem afterwards. So the treatment should be aimed at reducing the pressure in a similar time frame to reduce decompensation rather than rushing this. So normalization of blood pressure in this emergency is typically tolerated most times. So we need to bring it down really fast. So this is one of them that you need to try and bring it down really fast. Don't give nifedipine again. So I've said nifedipine so many times in this case. Beta blockers in this case will be avoided. Even though we say beta blockers are used in heart failure, this is not the kind of heart failure where we use beta blockers. Because what will happen is that heart is unable to pump against that high pressure. Then you give a beta blocker which reduces the power of the heart. Of course, that pressure will overwhelm it, which means that the pulmonary edema will worsen dramatically before your eyes and the patient will die. So beta blockers, nifedipine, all of that should typically not be used because they will increase the burden of the. So we will try and we'll put this on YouTube so that you can watch it again, and we'll probably send some slides if requested so that you can look through it and go through it at your spare time, because there's a lot of information to digest in one sitting. So, but take notes. If you don't take notes, you will not remember most of it, even if you give it slides. Okay, so the treatment now should be aimed at reducing the pressure, not necessarily just the volume. So in most cases, what we do is to give the nitroglycerin, okay, AC inhibitors, IV or whatever, and you bring down the blood pressure and you're very before. Now, if you don't have IV nitroglycerin, a reasonable alternative by most authors is to use sublingual nitroglycerin, GTM, but you must use it cautiously. If you give it, you must be checking the blood pressure. You must have that ICU care. You must check the blood pressure in between. You must watch out for rapid drops. So if you give that, you might be able to bring down the blood pressure, and in your very before, the pulmonary edema will actually disappear with or without furosemide or loop diuretics, because you understand the basis now of how it is working. Now, aortic dissection, I told you that the inner wall is peeling, and it can be type A or type B. Most of them are very, very difficult to manage, extremely difficult to manage. We've had a couple of cases, we've managed them successfully, and then we had surgery carried out by a partner center to repair the aortic dissection. It was a very serious one, because they had to also replace the aortic valve. Okay. So for aortic dissection, you have to be, the blood pressure is very critical, because the higher blood pressure, it will keep on tearing. So I told you that it is the inner wall of the inner wall of the artery is tearing, and so there will be two lumen. There will be blood in one lumen and there will be blood in that lumen. The higher the blood pressure, the tearing continues, the shearing continues, and typically the mortality is very high. I think I've seen a patient when back there when I was training. I mean, we lost the patient. It was very difficult to get the patient into surgery at that time, but now it's a lot better in Nigeria. Okay, so you are trying to reduce the shearing forces. You're trying to lower both the blood pressure and the pulse rate. Okay, and the recommendation in this case, however, is to get blood pressure, systolic blood pressure, to less than 100. Yes, you heard me right. So you want that systolic to be less than 100 to 110. So if you are getting 90 something, 60, that is great blood pressure. If you are getting 101, okay, that is okay. So between 100 and 110 of your systolic, not diastolic, that is your target in aortic dissection. Aortic dissection, you typically will find it, blood pressure is different on both wings. There's central chest pain, there's a widening mediastinum, echo has seen part of it sometimes, or you did a CT, a chest CT, and you saw it. This is what you have to do, and you have to do this fast in an ICU setting, otherwise you lose the patient before your very eyes. Okay? So a beta blocker is typically used. It also reduces the pulse. Nitroprusside is a vasodilator, and it's typically the preferred agent in this region. So labetalol can also be used. So if you don't have nitroprusside, labetalol can also be used, but you need to be careful about that. So this is aggressive blood pressure monitoring, aggressive blood pressure reduction is what we are looking for, with a heart rate 50 to 60 beats per minute. Now, if there is hypotension, the patient comes with aortic dissection, and the blood pressure is not very high at the time you are seen, you need to suspect that the aorta has ruptured, or there's a hemopericardium with a tamponade. And you need to have an urgent echo and an urgent pericardiocentesis, or I mean, urgent getting your cardiothoracic surgeons immediately to assist. In renal failure, you need to act swiftly to bring down that blood pressure to preserve renal function, because if you don't do it fast enough, then what may just have been an acute kidney injury will get turned to a chronic injury if you are not done well. So the same things we talked about, not too fast, just like we talked about. However, the drug of choice is phenoldopan. And the reason is that phenoldopan dilates arterioles, so it improves blood flow to the kidneys, and that is quite important. Okay, nicardipine is also an alternative that you can use. Now in stroke, I've talked about the prognosis and if you're too aggressive about the blood pressure. And the reason is the concept of the penumbra, which is that after the blood supply has been disrupted in acute, that's in ischemic stroke, after blood supply has been disrupted to a particular region of the heart. Okay, I'm just checking comments. After blood pressure after blood flow has been disrupted to a particular part of the brain, that place may have died, all right, but there's an area around that area that is still in between. Okay, so if you bring down the blood pressure too fast, the blood supply to the brain will reduce sharply and that area will get converted, so the patient will worsen. So you don't want to bring down that blood pressure fast at all. You want to take time and bring it down properly. And we'll talk about that a little. So in intracerebral hemorrhage, same thing here. You need to bring down the blood pressure because if you don't bring down the blood pressure, the same thing can happen. The hematoma will start expanding, but you also have to be careful with the blood pressure. If you crash the blood pressure too, the same thing will happen. There will be reduction in blood flow and then worsening of the event. Remember that this is the central equation in blood pressure control. In blood pressure control in stroke, this is the central equation. Whatever you do, make sure you remember this equation. This equation is key. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So once a patient has suffered a stroke, what happens is that the intracranial pressure rises sharply because of cerebral edema. So what then happens? The blood pressure that you are seeing most times is a protective mechanism. The blood pressure, the MAP has to rise higher so that cerebral perfusion pressure can be raised, can be maintained. So let me use a mathematical example. Let's assume cerebral perfusion pressure is 30. Intracranial pressure is 100. Intracranial pressure is 70. 100 minus 70 equals 30. Abi? If intracranial pressure rises to 110, the mean arterial pressure must rise to 140 to maintain that cerebral pressure at 30. Do you understand? So that mean arterial pressure has to go up to maintain brain blood pressure supply. So if you drop that mean arterial pressure suddenly, what happens? The cerebral perfusion pressure will also crash and the patient gets worsened, goes unconscious, or even dies. Okay, so that is why you have to bring it down, and you have to not just bring down the blood pressure, you have to also treat the intracranial pressure. Sometimes the blood pressure you are seeing in a stroke is actually a secondary hypertension. That is because of this same mechanism that we've talked about. This is the mechanism that is causing the blood pressure to rise so fast. Okay, so in that kind of case, if you have to bring down intracranial pressure and you see the blood pressure drop. We had a patient admitted even 2 days ago, before yesterday, minimal deficits, just came with a blood pressure 160/100, and this underscores 180/110, and this underscores why you must say that, why we say that there is no specific value that determines an emergency. Feel too weak, but there was some mild facial deviation, some mild CT scan, and when with the CT scan, what we got was cerebral perfusion pressure. What we saw on the CT scan essentially was a hemorrhage. The man had a hemorrhagic stroke, walking around and just came and said he's feeling one kind. And if you don't check carefully, you might rush and give antihypertensive and say go home. When you give antihypertensive, you will reduce the mean arterial pressure, cerebral perfusion pressure will be worse, the patient will come back unconscious or with worsening weakness, and that would have been very bad. So that's why we must be very careful. And this is one of the reasons why we decided to take on this topic. Okay, so in a hemorrhagic stroke, you want to aim to get your systolic blood pressure to about 160. Okay, sometimes patients with elevated intracranial pressure may have to undergo ventriculostomy so that they can maintain cerebral perfusion pressure between 60 and 80, but this may be beyond the scope of this lecture. Okay, so when you want to reduce the blood pressure, just like in ischemic stroke, you still don't want to bring down the blood pressure below more than 20% in the 24-hour period. What do you do first? First, take care of the intracranial pressure. Give your mannitol and Lasix mannitol first, 20% mannitol, not 10%. Giving fast, about 250 mils, 1 to 2 milligrams per kg. Okay, you give it very fast, over 15 minutes. Then you follow it up with Lasix about 15 minutes later. Watch it. Typically, after that, the blood pressure will come down. If that blood pressure comes down and is still having an MAP above 145, then you might be, then you need to intervene, or quite high. Or if you want to intervene, you can't intervene, but you try and bring it down gradually. These are the agents that you use. Now, hydralazine is there, but you must be very cautious use, because remember, hydralazine raises the intracranial pressure. So when the intracranial pressure is raised, at a lower blood pressure, the patient may not get enough cerebral perfusion pressure. So you must have all the gadgets in place before you use hydralazine in an ischemic stroke, in an ischemic or hemorrhagic stroke. Okay, so you try and bring down the blood pressure, careful monitoring of the blood pressure. For ischemic stroke, our aim is lower blood pressure only. You only lower the blood pressure only when it's greater than 220 over 110. If you are planning to do a thrombolysis, which is hardly done in Nigeria, we've tried to do 1 or 2, but it typically depends on the patient coming in early. The patient does not get to you before 4.5 hours, and you make a diagnosis via CT within 3 to 4.5 hours, preferably less than 3 hours. Then it's very difficult. It's not typically advised to do that. But if you're able to do that, you have to bring down the blood pressure to 130 to 180 over 105 before thrombolysis. Okay, and we can also do that in our cath lab, and then you try and get that down. But if there's no thrombolysis, just do the reduction of the intracranial pressure. Don't touch it, except the blood pressure is above 220 over 110 or mid-arterial pressure greater than 145. This attempt of leaving the blood pressure high is what is known as permissive hypertension. Okay, I hope we are getting a lot. Sorry, there's quite a lot to talk about. Okay, so Dr. Obviously has offered to answer some of the questions while I catch my breath, so that will be great. All right, so we'll do that shortly. We're almost done. As we get done, then we'll start answering the questions. There are quite a number of questions. We'll start answering them. Okay, so if blood pressure reduction is needed in this case, you should be very cautious. However, there are times when, because the patient might be having an ischemic stroke and having a heart failure at the same time. In that time now, you need to bring down the blood pressure. You may need to bring that pressure even much more. So those are the reasons why you may have to be, blood pressure might be 190, 110 in 190, 100, and is having ischemic stroke. Typically, you will not touch that. But if the patient is having acute cardiogenic pulmonary edema, you now have to touch the blood pressure, but still you have to do it gradually and manage it. This kind of one typically should be there for a specialist, okay, or at least to have the input of a specialist. Okay, so there's no specific agent preferred in ischemic stroke, but typically you like to use one that you can, if your blood pressure is falling too fast, you can stop. Not the ones that are long acting. Another problem is hydralazine. You give it, it can last up to 4 or 5 hours. If your blood pressure has dropped too much and you stop, your blood pressure will remain down and causing damage till, while some of them, once you stop, then the blood pressure goes back up. So that's why the shorter acting ones are better. And then you have subarachnoid hemorrhage. It's very important to treat the blood pressure because of rebleeding and vasospasm that can occur. Okay, and the preferred agent for subarachnoid hemorrhage is nimodipine. Nimodipine is very much available. And one of the reasons why you use nimodipine rather than nifedipine and another one is that nimodipine prevents vascular spasm. And most of the problem that you have with subarachnoid hemorrhage is vascular spasm that happens typically 4 hours to 4 days after the stroke. So you have to be careful. So if you use nimodipine, you bring down the blood pressure, but you also get the vessels in the brain, you keep them open. So there's this slide, it's quite busy, but it's a very important slide published in the Journal of American Medical Association in 2006 by Chobanian. So it kind of gives you an idea, and you should have this in your clinic somewhere on a wall somewhere. What is your blood pressure goal? Hypertensive encephalopathy, you want to do it 10 to 25% reduction over 8 to 24 hours. Labetalol is preferred, nicardipine is preferred. MI, the same thing, labetalol or nitroglycerin. Remember, we also give beta blockers in MI. Okay, renal failure, phenoldopan. Remember why we say phenoldopan? Because it increases renal perfusion. Okay, and then in hemorrhagic stroke, our goal is to get the mid-arterial pressure less than 130. Okay, in that case, nicardipine or labetalol is used. However, if you have subarachnoid hemorrhage, we said we are going to use which one? Nimodipine, and then you can add these other ones. Okay. Then after dissection, your target is 100, less than 100 to 120. So your systolic will go down. Okay, you want to bring that blood pressure down. We had that patient I told you about, a young lady, maybe 35, had been 32. I've been having that thing. Actually started during pregnancy, and everybody thought it was pregnancy related, but severe aortic dissection. We had to replace the aortic valve as well as replace part of the aortic arc for her. Very interesting surgery, and she's very well much alive. She's been coming for follow-up. So you have to bring this on. We kept it down. We kept the blood pressure very low till we'll take her in for surgery. Ischemic stroke. And remember, when systolic blood pressure greater than 220 or 110, or if you have arterial pressure greater than 145, you should consider bringing it down. But you need to bring it down very slowly and casually. Remember, I said 10% over 8 hours, and you still want to keep your blood pressure. You have to have what you call permissive hypertension. In active left ventricular failure, you can use nicardipine. Furosemide can be used. However, remember that if the patient was euvolemic before they had a active ventricular failure, it might have a deleterious effect downstream because it causes reduces the overall blood volume, which was not elevated in the first place. So once it reduces overall blood flow, that reduced blood flow to the kidney might trigger a RNA system to further worsen blood pressure control downstream. So you need to be cautious about that. Typically, we say nitroglycerin can be used. These are some of the drugs you can use, nitroprusside, and you can see why nitroprusside is the one most preferred in most emergencies. So it's one of the drugs that you typically should have. Not very available around Nigeria like that, but sometimes it's available. You can get it anytime we travel, try and get some into the hospital. Why people like it very much? It acts immediately. And then when the duration of action is 3 to 5 minutes. So if you think blood pressure is dropping too much, if you stop it in 5 minutes, it has stopped acting. So you're not afraid. The only problem is that if you have patients with creatinine that is high, liver or kidney failure, it might cause thiocyanate and cyanide poisoning. So you need to be careful about that and cautious about that. Nitroglycerin also has similar properties, and it's typically when there is a concomitant heart disease. Remember that headache typically occurs. The tolerance can happen. After a while, you need higher and higher doses. Then labetalol. Now, labetalol acts for up to 1 to 8 hours. So that is why you should also be cautious. Remember that labetalol is not used in left ventricular failure. That is cardiogenic pulmonary edema. And it's also can cause a heart block. So you should also remember that. Even if you are treating patients with eclampsia, remember that they can have a heart block. You are treating them, the blood pressure is coming down, all of a sudden the pulse has become 40, 45. That patient could have had a heart block, and that could be from the drug. Okay? So you could put it in infusion, and these are the different doses. And then you have nicardipine, which I said most emergencies, except those that have heart failure. Okay? And remember, I'll use it for a lot of the ones in the brain. Then we have clevidipine and the others. Now, phentolamine is quite a very important one, and it's typically reserved for pheochromocytoma. Okay? And now, in pheochromocytoma, you must also not use beta blockers early. First, you must let me not waste time here. Okay, then hydrolysis, I'll talk about it later. Eclampsia, this is one of the only places why hydrolysis is typically accepted. Give it within 10-20 minutes to begin to have an effect, but I will still advise that I think I still prefer labetalol over hydrolysis in eclampsia. And the reason I, personally as a specialist, prefer that is that in patients with eclampsia, especially when they are obtunded, they are having seizures, they are unconscious, if you give hydrolysis and sometimes they are also having a raised intracranial pressure, if hydrolysis is further raising the intracranial pressure, I may not be good. Okay, so that's why I like to keep it for other things, but it's also very good. This is one of the places where it's indicated. And then enalapril as IV, I've never seen this drug, but it's especially for people that have scleroderma that have the MAT crisis, it is quite important. And phenoldopa, like we said, for renal failure, is quite important. So, in summary, hypertensive urgency and emergency, you need to be able to define it. You need to be able to know what you are doing, because you can cause it, or the disease itself can cause problems in mobility and mortality. Okay, the urgency is defined as greater than 110, greater than 120 without evidence of end organ damage, while the emergency, there is end organ damage and you need to start bringing down the blood pressure in an ICU setting. Okay, blood pressure should generally, except for the specific situations like aortic dissection I've talked about, It should not be lowered more than 10 to 25% within the first hour. And then normalization. The patient is even having eclampsia, and the blood pressure is 200 over something. You are just trying to bring that 200 to not more than 180. It's not, 200 to 180. Don't try and aim for 200 to 140. You will cause more harm than good. And the patient never wakes up and you have problems. Okay, so you're trying to bring it down within the first hour. Okay, and then if you're having a stroke, especially ischemic stroke, we have what is called permissive hypertension, where we allow some level of hypertension because we want to perfuse the brain while we're reducing the cranial pressure. And then there are particular instances where we must bring down the blood pressure. Okay, above all, do no harm. So this is CardioCare Specialty Hospital. It's in Gariki. Is sponsoring this webinar. So specialists are on the panel, and some of them will start answering some of the questions while I take a drink of water. It's located in Gariki area 11, Abuja, Nigeria. Just to try and help, this is our patient's lounge when they are doing procedures like cath lab procedures. This is where the patient and the family wait. This is what the building looks like. It's facing Amado Bello Way, and so it's quite easy to recognize. And then we do all the MIs and the strokes and diabetes, dialysis, and all that. CardioCare is also from Limi Hospital, which also has Limi Hospital in Central Area and Limi Children's Hospital. And in a couple of days, we're going to be announcing, Limi Hospital is going to take over after this, and we're going to be doing COVID and pregnancy. So what to do in antenatal and delivery for COVID and pregnancy. So that's a very interesting webinar that I would like to go on to. So I will unmute Dr. Pathophysiology now, who will start answering some of the questions straight away. Let me see, just a minute. Okay, Dr. Pathophysiology, over to you.
Okay, trying to get this question and answers to open.
Dr. Pathophysiology?
Hey, is my audio clear?
Okay, so let me start answering some of the questions. Dr. Olale Country is another cardiologist in, okay, you can hear him. Okay, please, go ahead.
Okay, can you hear me? Okay, yeah, so I'll take the first question now. The first question states that if the mean arterial blood pressure is greater than 145 millimeters of mercury and is an hypertensive urgency, do we use parenteral or oral antihypertensive medications? And I think that from the presentation, this should be a bit clear, but I'll just elaborate a bit on that further now. The first thing we should remember is that the main thing that distinguishes between an hypertensive urgency and emergency is the presence of acute ongoing end organ damage, okay? Now, if we have decided that this is indeed an emergency, there is usually no role for parenteral medication. So usually oral medications will suffice, except of course, if there are other indications why the person may need parenteral medications. Let's say someone that is just immediate post-op, is on MPO, or some other issues like that, okay? But hypertensive urgencies on their own will not warrant parenteral medication. So almost always is oral medication. And we should aim to bring down the blood pressure gradually, usually by between 10 to 25% of the systolic blood pressure over 8 hours or so, like Dr. Sekos mentioned earlier. So I hope that clarifies it. If there's need for further clarification, please, you can just type again in the chat box. The second question says that, is antihypertensives, are they taken for life? And then in the event of blood pressure dropping to 90/60, should the dose be halved or stopped? Okay, so the answer to that question is that generally the treatment of high blood pressure is lifelong, because high blood pressure is a lifelong condition, okay? So the treatment is lifelong. And the treatment, we should remember, composes of both non-pharmacological and pharmacological treatment. Now, the pharmacological component of the treatment is usually lifelong, okay? But the medications needs to be reviewed from time to time, okay? So obviously, someone who is on high blood pressure medications and the blood pressure is getting to 90/60, the medication should be reviewed. Is it that the medication is too much, one, or there is a new thing that is ongoing at that time. Okay, so new things that are ongoing at that time, someone can have an ongoing infection, can have an ongoing infection, maybe dehydrated, okay? And then sometimes we should also put in view, sometimes the initial diagnosis could have been erroneous, that's one, or the medication weight that the patient is on is too much, that's two. Or lastly, sometimes the patient could be doing more and more lifestyle modifications that is getting the blood pressure, that is really helping the blood pressure. And in such circumstances, it's totally appropriate to reduce the dose of medications. And yes, some patients with high blood pressure medications can actually go off medications sometimes, especially if they're doing a lot of intensive lifestyle modifications. But it has to be done very cautiously, and it usually needs to be done with a lot of monitoring. And typically for us, before we make such decisions, we do a 24-hour blood pressure profile. That's an ambulatory blood pressure profile in which a person wears a BP device for about 24 hours, and then we analyze the blood pressure pattern. And even if we stop the blood pressure medication, we do the blood pressure profile again, maybe about a week or 2 weeks after, and then such patient has to continually monitor the blood pressure over a long time. So yes, it's appropriate for the dose to be reviewed, to be reduced or reviewed. And actually everybody who is on high blood pressure medications should be on long-term review, and hardly should someone be on the same dose for indefinitely. No, the medication usually needs to be reviewed. The next question talks about sublingual nifedipine. You said that we should not give sublingual nifedipine in a patient with hypertensive crisis.
Yes.
I did not get the explanation. If you can explain again, because that's the practice where he or she works. Well, the answer to that is that giving sublingual nifedipine was a common practice actually for many years. Okay, but since over 10 to 20 years ago, it has been realized that sublingual nifedipine actually has a very high risk of causing harm, and it's actually caused harm for a lot of patients. And the underlying reason, like Dr. Iseko explained, is that it can cause a precipitous drop in the blood pressure. Don't forget that sublingually, nifedipine can act as a very strong vasodilator, okay? And because of this vasodilation that it causes, it can cause the blood pressure to drop very fast, which can cause ischemia in the distal blood vessels. So it can, if it's given sublingually, the blood pressure can drop very fast because the sublingual almost works like an intravenous nifedipine. So it can drop very fast, even though that's a bit erratic and unpredictable, okay, but it can drop very fast, and the person can get quite hypotensive rapidly and can have a lot of ischemia, and the blood pressure usually bounces back up again after that precipitous drop. So it's very dangerous, and I think FDA has a standing statement against use of sublingual nifedipine. So nifedipine should never be used sublingually. Okay, someone made a comment that it's mostly difficult to time the inception of severe elevated blood pressure. Yes, that's true. Usually it may be very difficult to tell how long a blood pressure has been severely elevated, okay? But the main job we have in hypertensive urgencies and emergencies is to determine if there is ongoing end organ damage and whether that ongoing end organ damage is acute and active, okay? So someone with severely elevated blood pressure that has crackles in the lungs, or that has an hematuria or proteinuria that we can presume to be new, or any of those 11 things that Dr. Iseko listed on the slides, those will make it qualify for hypertensive emergencies. Okay, but in the absence of those, it's usually an emergency, and then we should treat each one on its own merits. The next question states that for a patient with chronic hypertension in which slight reduction in blood pressure brings hypotensive symptoms, what should we do? Should we keep the blood pressure in that elevated state, or should we go on and reduce it? What I would say is that many patients have their own peculiarities, and we should be quite responsive to those kind of patients. Okay, but the key thing I would say is that if you have patients that respond to our BP agents like that, it's often helpful to try other blood pressure lowering agents. Okay, so if we did like that with a ACE inhibitor or ARB, you could try a calcium channel blocker. So usually when you explore a few different agents, usually you find one that the patient tolerates and the patient does not experience those hypotensive symptoms. Another thing that can be done, obviously, is starting from a very low dose of the medication and taking our time to titrate it upwards, okay? It's also very important that we identify, understand, and relate with psychological aspect of patient symptoms. For example, there's no way that a blood pressure reduction of from 160/100 to 150/90 will be the cause of a patient's hypotensive-like symptoms, okay? So when patients have some perceptions like that, we should try to understand with them and just walk the path with them that they're willing to go through. Many of them are usually happy with changing medication or using a lower dose or getting to the target slowly. So trying not to get to the target very fast may be appropriate for such patients, but it will not be appropriate to keep someone's blood pressure high at, for example, 150/90, because the patient apparently has some symptoms when the blood pressure gets to 130/80. No, it won't be appropriate to keep that blood pressure elevated, okay? Okay, so I think that's that. Running through the pathophysiology again, I think I'll leave Dr. Iseko to go through that again. And how do we stratify patients that will require intensive care or close monitoring, as the two are very different in real life, in clinical practice? I think I'll presume that this person is asking about patients with hypertensive emergencies, okay? So patients with hypertensive emergencies, if we really understand what hypertensive emergencies are, they are ICU issues, actually. They are not patients that should be managed in an open ward. Okay, so ICU or at least an HDU. Okay, but I know that we're in Nigeria and I know that our practices have their own limitations. Okay, so for hypertensive emergencies, it will actually be only when there is no ICU or HDU facilities and there's nowhere maybe close by that the patient can be referred to, that we can settle for close monitoring. Okay, because if you look at those diagnoses under hypertensive emergencies, if a patient has an acute stroke, cerebral hemorrhage, ischemic heart disease, things like that, with a very elevated blood pressure, and you are contemplating lowering the blood pressure with intravenous agents, the person usually will require at least an HDU. Okay, but if an HDU is not available in your clinical settings, then a very close monitoring might suffice, of course, despite its risks. Okay, so this question here says that what are the symptoms and signs that suggest a pheochromocytoma? I hope that's, okay, so one of the first thing I'll say about this is that pheochromocytoma has been dubbed the great masquerader. It's written like that in many textbooks. So it's difficult to really say one symptom or sign particularly, okay, but I'll just mention the key ones that can be quite suggestive, okay? So if a person has paroxysmal symptoms, usually the paroxysmal consists of palpitations, sweatings, and headaches, and extreme fear, just that adrenaline-like symptoms. So if patients have those kind of paroxysmal symptoms, it can be quite suggestive. During those paroxysms, if it's documented that the patient has surge up of blood pressures that lasts brief moments, usually just minutes actually. So the blood pressure and pulse surges up. That can be quite suggestive as well. And in the presence of, in the presence of orthostatic hypotension as well, that's postural dizziness, can be quite suggestive. One of the pheochromocytoma patients I've managed before, I remember that when we were checking the blood pressure on the ward, someone checked the blood pressure was around 220 over something, pulse rate in the excess of 140, and then the next person was just checking it just to confirm, and the blood pressure was around 100 over 60. So it can just surge up and down like that, and we can understand that knowing that the pheochromocytoma tumor is there in the adrenal gland, and anything, either humoral stimulus within the body, or sometimes even just pressure, that like changes in position or someone pressing the abdomen, can cause some of the hormones to just be released out from the gland, and it just causes that surge, and that surge goes down. So I think it's that paroxysmal episodes of the cluster of symptoms that can be most suggestive of pheochromocytoma. Someone mentioned that is the rule of bringing down blood pressure slowly the same with hydralazine used in O&G? I would say that the guidelines for managing blood pressure in preeclampsia in O&G is different, okay? But always blood pressure should be brought down slowly. Blood pressure should never be brought down precipitously. Actually, almost always causes more harm than good. Okay, but the percentages that we quoted about that 10 to 25% reduction in the first 8 hours will not work for preeclampsia. And don't forget that preeclampsia itself is not an hypertensive emergency. If the pressure is so high and there are threats, it can be considered an urgency. Okay, but most people with preeclampsia will hardly be an urgency. Okay, but blood pressure should always be brought down slowly, and it should never be brought down rapidly, usually. What are the guidelines for treating hypertensive urgencies? Well, most guidelines for management of hypertension, I'm aware of the AHA guideline, has some segments on it for hypertensive urgencies and emergencies. And is a summary of those segments that actually form they informed the information given in this presentation. So I think that would be a reasonable answer to that question. And someone is asking, I think we can use sublingual nitroglycerin in myocardial infarction. Yes, sublingual nitroglycerin has a role in myocardial infarction, both sublingual and IV nitroglycerin, even though sublingual will probably have more role in myocardial infarction. Of course, that's a transient role. We both know that the main treatment for myocardial infarction will be coronary angiography and stent insertion or coronary artery bypass graft. Okay, but if there's infarction, it's still reasonable to use sublingual nitroglycerin, especially if the blood pressure is strong enough to take it. And Dr. Iseko talked about the acronym MONA, that's M-O-N-A. The N there stands for nitrates, which is often sublingual, even though it can be parenteral, that's IV as well. Okay, so someone is asking here that, do all patients with hypertensive urgency need hospitalization? Okay, Dr. Iseko mentioned that specifically that not all patients with hypertensive urgency will need hospitalization, even though it's good clinical practice to observe such patients for a very lengthy stretch.
Hello, is there a problem? Okay, I think there's some. So maybe I'll just step in. I don't know what's happening. I can't hear Dr. Officer again. If anybody can hear him, maybe you should just. We can't hear anymore. Okay, can you hear me? Can you hear me? Okay, great. Thank you, Philomena Ehi. Okay, so I'm going to talk about, the question was about, what question was he answering now? About whether I should admit everybody with hypertension emergency. Okay, so it depends. So most patients you may need to admit. Some patients you may not be able to admit either because of financial or other issues, but you don't have to admit. Now, for patients, if you think that they may quickly progress into an emergency, you need to admit. So if you have the wherewithal, you can admit at least for 24 hours in an observational hospital setting. So in a calm place, you keep them, you give them their oral medications, you watch over 6 to 8 hours, or you keep them in your observation room for some time, start your oral medications, watch, and then you allow them to go home and then come back later. Please, you need to find out about the other medications. So sometimes some patients have been taking some other drugs. Maybe they went to another doctor, they saw you, then they went to another doctor. Okay, Dr. are you back?
Yes, I'm back. I'm back, sir.
So maybe they saw you and then they went to another doctor.
Can I continue?
And got another drug. Then you now get them drug, you take everything together. So sometimes also, the reason why you might admit a hypertension urgency is if you are not sure of whether the patient will come back the next day, or you'll be able to monitor or trust the patient to do what is right. So you have to just keep them in the hospital, get them in. Sometimes you also use the opportunity to counsel them and their families together. Okay. Please run through the pathophysiology again. That running will be very fast. Just a minute, I'll go back to that one. Okay. Now in O and G, the blood pressure, definitely still you don't want to bring it down more than 10% in the first 1 hour. So that first 1 hour, try and bring it down first a little before you now continue. Don't try and crash it from that high to that low at the same time. So you bring it down first slowly before you continue to go around. What are the guidelines for treating hypertension urgency? So we talked about them already. We said that we want to bring it down. We want to treat the blood pressure over days to weeks. So you don't want to achieve the good blood pressure control within 24 hours. You want to get about 25% blood pressure reduction within 24 hours first. So the pressure was 200 over whatever, systolic blood pressure was 200. Over 24 hours, then you think you are bringing down to 160 or thereabouts, you know, that kind of gradual reduction, okay? I think we can use sublingual nitroglycerin in MI. Of course, we use sublingual nitroglycerin, but typically we'll not use it in MI. In an MI setting, it's better to have IV. And why is that? Sublingual nitroglycerin, you cannot control it. If you put it in and and the blood pressure drops rapidly, you cannot do anything about it. So it's better to have your IV nitroglycerin there, ready to, and then if the blood pressure is falling too fast, you can adjust it. So that is why I don't recommend that. But if you have an acute cardiogenic pulmonary edema, very high blood pressure, then you can give small doses, watch it and monitor it. Okay. Okay, so, and then you say in treatment of hypertension urgency, can patients who are non-drug compliant take the antihypertensives they are on, or do we have agents listed in the presentation? Or do we have to use agents? So if a patient has not been taking the medications for a long time and comes with you with an urgency, it is typically not very nice to start all of them at the same time, especially if they have stopped the medications for a long time. So somebody has stopped medication for 3 months, and then or 2 months, and then came to you and said, okay, because of COVID, he could not get drugs. And for 1.5 months, he has been, then you saw the blood pressure at 190, 130. You definitely cannot give him all the drugs at the same time, because what will happen, the blood pressure will come down to normal within 24 hours. That will be catastrophic, maybe catastrophic. So you want to give him a smaller amount of medication first, then after a few days, a day or two, you check again, then you give him the other ones, so that over 3 days, 2 to 3 days, you cannot, or 1 week, you cannot bring it down slowly. If a patient is having symptoms, they're having dizziness, there are several things that can happen, that could have happened. Number one is that you may be using the wrong agents. If you are using too much of diuretics, you may be causing hypovolemia. So you are giving diuretic, you are giving maybe another diuretic, the patient is urinating. So they are actually hypovolemic. So when they stand up, they are feeling dizzy. It's not because the blood pressure is too low, but it's because there is hypovolemia. In that case, you need to change or check the kind of antihypertensive you are using. Sometimes you're using the wrong combination of antihypertensive. I've seen sometimes some people doing ACE inhibitor and ARB together. If you do that kind of one, you may have that kind of problem that can happen from time to time. So you may have to pull it off. Okay. So if you have any questions, please just put it in the Q&A box, and then we'll answer it straight away. So you said FUSEMA should be avoided in pulmonary edema, acute ventricular failure. What if the patient is a known heart failure patient and hypertensive heart disease patients who present with acute fluid overload in the lungs may not be taking fluids regularly? So I said that the furosemide used in acute cardiopulmonary pulmonary edema, you should be cautious if the patient was euvolemic before. So the patient does not have any fluid overload. The patient is dry, very fine otherwise, and all of a sudden they become breathless, they are having lung fluid all over their lungs. You will check them, there is no pedal edema, there is no Washerman sign. They were otherwise fine. If you are not giving the furosemide, you might be pulling out fluid from the intravascular space, which might worsen it down the line. So that's the cardiovascular people. But if the patient has pulmonary edema, has pedal edema, has everything, then using furosemide is definitely no problem, because they're not going to be pulling from the intravascular space. They're going to be pulling from the extravascular space as well, and that will be quite important. Okay. What do you do to a patient with hypertension emergency encephalopathy, where that you give a maximum dose of IV labetalol, but BP is still above 190, 130, and patient is still restless? Number one, you have to be sure that you're treating hypertension emergency. in this kind of case, I will think that you are not taking a treatment hypertension emergency. The patient you are looking at may be having a stroke. So if you are sure that you have done a good neurological examination, you have done a cranial CT, and you are sure about your finding and there's no neurologic deficit and the blood pressure is still high, then you have to do something about that. Typically, at this point in time, you need to check renal function. That patient, most patients that are still having very high blood pressure, uncontrolled, with very high doses of drug, typically are having other things. Sometimes there's also a concurrent raised intracranial pressure. Remember that hypertensive encephalopathy, remember how we described the pathophysiology of encephalopathy, that there is pressure, microhemorrhages, and edema most times in the brain. So if you give some mannitol and Lasix, it will also help to control that blood pressure. Okay, so but you need to be careful. Most times when we see patients with unresponsive blood pressure in an encephalopathy, chances are that patient has had a stroke, and it's not that the patient is not responding. At what level? To what level should you reduce blood pressure in a patient with aortic dissection without compromising organ dysfunction? Okay, so definitely you have to be, our target for aortic dissection is 110, highest 120 of systolic blood pressure. In aortic dissection, yes, there is problem of organ dysfunction, of compromising organ perfusion, but the benefit outweighs the risk. Blood pressure are above 120, systolic above 120 have been associated with a very high mortality, especially if it is type A or type B dissections. So at that point, you typically have to bring down that blood pressure a little. So some people ask a lot of questions. Some of them I type the answers. We didn't answer all verbally. So other people can look to the questions and the answers and get some insights as well. So for aortic dissection, your primary aim is that high blood pressure above 120 is going to continue sharing. And if you don't do anything about it, that is going to die before your very eyes. So with that risk benefit looked at, you need to check whether you need to bring down that blood pressure. Now, of course, you need to be monitoring the patient. So this is the kind of patient that you need to have your interarterial line. As you are checking the interarterial line, you can see the blood pressure, and you can be checking your GCS. So by the time you start seeing any signs of oxidation, which I get you too confused, other mental status, then you probably need to slow down a little, like we said in the presentation, slow down, reduce. So that's why it's best to use nitroprusside, like we said. Nitroprusside will stop working within 3 to 5 minutes. So once you start reducing nitroprusside, the blood pressures can start going back, and you will see changes. So this is not the kind of patient that you just give the treatment and you go away. You must be there, seated with that patient, looking at it and monitoring. That's why it has to be an ICU care. Okay, and of course, remember that in patients with aortic dissection, you are doing that with an aim to get into surgery, typically. Okay, so it's a bridge to surgery, and you cannot go in with that high pressures. Otherwise, it's going to share. Now, there are reasons why you don't use so many other drugs in aortic dissection, and that's because the drug that you use must also reduce the wall pressure and the shearing force. So there's something called dP over dt, which talks about the wall tension and the wall pressure, and that determines the kind of blood pressure medication that you use to help reduce that kind of blood pressure. Okay. If you have any follow-up question, please ask. I think that was Dr. Fafuri. Okay, good day, and thank you for this update in these challenging times. I wanted to know how I can get the slide. So your network is not so great. Sorry about that. So as soon as we finish answering the questions, I will show you a slide which will show you the Facebook page, what do you call it? YouTube page. So we're going to upload within 5 days. This whole presentation will upload on YouTube, so you can watch at your convenience. And then on Facebook, you can rewatch it even over the next 12 to 24 hours. You can watch it again on Facebook. So if you go on Facebook, you see this presentation. On that, I will show you the places, and I'll tell you how we're going to get the next presentation, which will be on COVID and pregnancy. Is there a way to predict normalcy of autoregulation in patients with high cerebral pressure, perfusion pressure maintained by high mean arterial pressure with normal? This is confirmed by CT findings. So you cannot predict autoregulation really. The idea is that autoregulation is typically maintained between mean arterial pressures of 90 to 150. And if the patient is chronically hypertensive, that shifts. Remember that our slide, it shifts to a higher value. So for you to be able to predict. All you need to do is once you get that blood pressure to that level, the bodies we should pick up normal. There's no, I have not come across any article that can predict, maybe Dr. Aleleko or Dr. Officer can. I don't think there's any way you can predict autoregulation. So autoregulation is a conceptual term that is used. It's not as if you can actually test it very well on the bed by clinically. Okay, so link for the COVID next webinar. I told you we will show it live. I will show it just immediately after we attend for the next one, which will be on COVID and pregnancy. And after that, we're going to treat chest pain in detail. Dr. Aleko is going to be taking that Dr. Aleko is a very sound teacher, very clean. You understand it very easily. So how to approach chest pain. So we'll talk about that, including ECG, echo, what to do, what not to do. Okay, so very important. Okay, so how frequent should one monitor end organ function at clinic visit level in hypertensive? Okay, to prevent cardiovascular disease. Really, at every time you are seeing a hypertensive, you should assess end organ function. But at first, at the time of diagnosis, every time a patient is diagnosed with hypertension, don't just say that hypertension and then you just start giving drugs. No, every time diagnosed with hypertension, you must do an ECG because you need to find out what is the baseline end organ dysfunction that is already present. You need to do a urinalysis. You need to check for proteinuria. The proteinuria is already there. It also changes the way you manage the patient. You need to check for diabetes. You need to do an echo. Okay, so sometimes you have hypertension. We've had a case, had hypertension, and we did the echo, and the patient had aortic stenosis. In those patients with aortic stenosis, if you give ACE inhibitor, the blood pressure will crash. Okay, that's a long time. I don't spend too much time because it will take me a long time to explain that pathophysiology. But the BP will crash before your very eyes. So here is having 160, 100, and then you give like Sinoprim 5, and the blood pressure slams to 90-60. Okay, so you have to be careful, and that is why, even though you're not finding everything in every patient, we typically recommend that patients, if they can afford it, they should have a full cardiovascular workup: echo, ECG, urinalysis, lipids, blood sugars, EUCR. You know, they should have that full workup. Try and identify as a primary cause, and then from time to time you do that. Now, an echo is typically, according to American Society, it's typically not recommended yearly. An echo is recommended only if symptoms change or if there is if there's something that does not. Okay, so I've answered that. How do we correlate the lipid findings from lipid profile, such as atherogenic index, against the prevention of MCI? Maybe it's MI trying to say. Sorry, this person says anonymous attendee. Can you clarify your question, please? Or Dr. Aleko or Dr. Aleko, do you understand the question? If you understand the question, you can attempt it, but I don't understand the question. So can you clarify your question, please? I don't know what MCI is. Okay. All right, can we get the slides? Yes, I've talked about that. How do you differentiate between acute left ventricular failure from heart failure? Okay, so acute left ventricular failure is actually heart failure. So it's just that. Dr. Aleko, you want to answer?
Okay. Hello, can you hear me, sir?
Yes.
Okay. So how do you differentiate acute left ventricular failure from heart failure? Dr. Officer, for some reason we're not hearing you. How do you differentiate acute left ventricular failure from heart failure? So acute left ventricular failure essentially is heart failure. It's just that we are saying it is more left ventricular than general heart failure. So you know, so it's essentially the term has actually changed from left ventricular failure to cardiogenic pulmonary edema. That is pulmonary edema occurring from the heart. Now, one of the ways you can do that is to put a Swan-Ganz catheter. So sometimes you put a Swan-Ganz catheter in, we measure the pulmonary capillary wedge pressure. That will help you differentiate if the pulmonary edema is from ARDS like COVID or if it is from the heart. So that pulmonary capillary wedge pressure will be very important. The second thing you can do to help differentiate left ventricular failure from other non-cardiogenic causes will be to do an N-terminal pro-BNP. Simple test, we do it in our center, we take the blood within 15 minutes to get a result. If it is greater than 300, typically, diagnosis of heart failure is very, very likely. So in these kind of cases, you will see it very high. And so BNP is an enzyme that is released from the atrium when the heart is stretched. So that is the second way. The third way is by echo. When you do your echo, we check the transmitral pressure. and we check what is called E over E prime. So when you look at an echo result, don't just look at only ejection fraction. Also look at E over E prime. If E over E prime is greater than 15, that will also indicate that the left atrial pressure is elevated quite significantly and typically from heart failure. Okay, so please, I didn't get the reason against use of hydralazine in eclampsia. Hydralazine is not wrong to use hydralazine in eclampsia. Let me say that again. I said personally, I don't like use hydralazine in eclampsia. You can use hydralazine in eclampsia as usual, but you must be cautious. If you are seeing signs of raised intracranial pressure, like bradycardia, a severe elevated blood pressure with bradycardia, patient is vomiting as well, then hydralazine may also further increase intracranial pressure. And so that may not be helpful in the long run. So you need to be careful about hydralazine in eclampsia. So that's why I tend to prefer labetalol to hydralazine in eclampsia. But hydralazine is very much usable in that situation. But don't use it in aortic dissection. It will not help matters. Don't use it in heart failure. It will not help matters. Don't use it in hypertensive encephalopathy. It will also raise the intracranial pressure and worsen the things. And the same reason why we say in eclampsia, Aldomet. Even though you're using Aldomet in pregnancy, you should be careful, especially when the patient is obtunded. Remember that Aldomet causes CNS depression. So the patient's altered mental status may linger a little longer than necessary. So you need to be careful about that also. Please, if you have any follow-up, don't hesitate to ask. Is there a place of ACIs in management of hypertensive urgency? Yes, very much. So you can start your AC inhibitors in hypertensive urgency. So remember that most of these patients in hypertensive urgency have either stopped their medications and then you have determined that, yes, there is no ongoing end organ damage. So you have no ongoing end organ damage. You want to bring the blood pressure down slowly. Yeah, you can use AC inhibitors oral. Also, if you have anything to add, Dr. Oladeko, if you have anything to add, please just go ahead and just talk. Okay. Can you give the current guidelines in managing hypertension? No, we can't do that now. That will take too long. Perhaps we'll schedule a webinar for guidelines of managing hypertension generally. So what we just do was hypertensive crisis. So for hypertension generally, that will take another long time. Otherwise, we'll give half answers. Okay, so we'll do that. Is there a criterion for admitting patients with hypertension? If one of the criteria for admitting patients with hypertension urgency is the likelihood of progression to emergency, what are the signs of imminent progression that should be looked out for? It's not as if it's a clear-cut thing. So what you're looking out for is that you have a patient with very high blood pressure, okay? You've seen an ECG, there's background abnormality, likely has left ventricular hypertrophy, likely has proteinuria, maybe old proteinuria, because if you have new proteinuria, it has become emergency, it's no longer urgency. Okay, so you are seeing some things, or you are seeing a patient that is not motivated. It looks like this patient is going to go home and say, okay, let him drink holy water and sleep. Or the patient is telling you already that, doctor, it's because I did not sleep, that is why. When I sleep, I'll be fine. You may need to admit that patient to be able to talk to. So that the only sign in that situation is a non-responsive patient, a patient you are not sure of follow-up, a patient, because if you give that patient drug that will just build up the blood pressure a little, and you don't follow the patient or counsel the patient properly, what may end up happening is that that patient, you never see them again, and they only come back with a stroke. Okay, so, okay. I think we've answered most. In what situation would a CT be preferable more than an MRI? Okay, so, Dr. Afisoye, Dr. Alekon, Afisoye.
In what situation will a CT scan be preferable more than an MRI, right?
Afisoye, are you there?
I'm here. Can you hear me clearly?
Dr. Alekon, my panelists are not able to get in.
I'm talking, sir.
So maybe I'll continue till they can work it out. So in what situation is a CT preferable than an MRI and vice versa? So a CT is very useful to help you exclude hemorrhage. So if a patient is having suspecting a hemorrhagic stroke, a CT typically will give you a better resolution for that. Very, very good. But however, if a patient is having an ischemic stroke, an MRI may be better, and even better, a functional MRI. So it may be better, it may give you findings early. So if a patient is having a stroke and they come, you have all the signs of the stroke, and within the first 3 to 6 hours, you do a CT. If it is ischemic, you may not find any abnormality or just subtle abnormalities. So you may not be able to be sure whether the person is having a stroke, but you can be sure that there's no blood. Okay, so those are the situations in this case where a CT would be preferable to an MRI or an MRI preferable to a CT. Can aortic dissection occur in the presence of normal blood pressure? Of course. Even if there is a normal blood pressure in aortic dissection, you must treat. Okay? So if you make the diagnosis of aortic dissection and there is normal blood pressure, you must treat. Why? The patient gets angry. The patient shouts. What happens? The blood pressure goes up. It tears a little bit more. So even if there is normal blood pressure in hypertensive, in aortic dissection, you must treat beta blockers and other ones that we've talked about to reduce both the pulse. Remember, we say we want to get the pulse as low as 50 something to 60 something. That's our target pulse rate. We want to get. Oh, you can hear one of the panelists. Oh, hello.
Hello, can you hear me?
Yes. Oh, sorry. Thank you very much.
Can you hear me, Dr. Seko?
Yes, I can hear you. Sorry about that.
Hello.
Yes, I can hear you. Go ahead. Go ahead.
Well, my connection seems good now anyway.
Go ahead. Go ahead. I can hear you.
Okay, I think I'll just let you continue, sir. Okay. I'm not sure which question you were answering, but I'm not sure you saw this question. What about the use of oral hydralazine? Is it as effective as the parenteral routes? My answer to that question will be that trying to use hydralazine orally would actually defeat the purpose for which the most situation in which we try to use it. Most situations when people try to use IV hydralazine is because they want to control the blood pressure on time and want to have a fine control on the blood pressure, which will not happen with oral hydralazine. And so for that reason, rather than using oral hydralazine, you will probably be better off using any of the other oral antihypertensive agents if you have an hypertensive urgency. Okay, but if we have an hypertensive emergencies, I think any of the other medication that was mentioned earlier in the presentation, especially IV labetalol, IV nitroprusside, and co, may be preferable rather than IV hydralazine for hypertensive emergencies in medicine. Is there any other outstanding question?
Yes, there's a question about atherogenic index against prevention of, I think the person has clarified that MCI is MI.
I can't see the question really.
Oh, you have to scroll up.
I have to scroll up, right?
Then there's some other questions which I have to open.
Okay, I really can't see it still anyway. But atherogenic index in the context of myocardial infarction, that's talking about, but that atherogenic index is more of atherosclerosis and dyslipidemia rather than blood pressure control, if I get the question correctly.
Yes, I think so. I think that's what he's trying to talk about. It's more of cholesterol and lipid profile in terms of an MI, in terms of prevention of MI.
So atherogenic index is just one of those lipid ratios that we talked about last week during the dyslipidemia treatments. It's one of those lipid ratios. I think it's triglyceride over HDL cholesterol, if I remember correctly. And that is one of the things that we use to determine starting treatments and in how aggressively we want to treat a patient for dyslipidemia or to reduce the cardiovascular risk factor. Okay, but that usually would not determine or affect how we control blood pressure in a patient with myocardial infarction. Okay, but if there's anything the person needs us to clarify specifically, I think the question can be typed again, so we'll have a look at it. Okay,
okay, so somebody said I should please quickly go over the I should go over the pathophysiology again. And somebody asked how can they get their CMEs from this session. So Yeah, so this is how we'll get the CMEs. This is how you get the CMEs. Just send a mail to cardiocaresymposia@gmail.com. We'll try and wait until the end of the series before we send all the CMEs. So that if you attended more than one, we give you all the CMEs on one CME certificate rather than giving you multiple small CMEs. So, or if you have any problem, you can also send to WhatsApp to 0809-333-5464. Or follow up on Facebook and Instagram, cardiocare.center. Any of our new seminars will be announced there as well. So once you're following us there, you'll get first-hand information about there. And also what we are doing now is also recorded there. So if you joined up late or you're able to miss most of it, if you go to Facebook now, you can actually rewind and start again. On YouTube, it will be there in a week or so. Last week's one is already there. There in about 3-4 days on YouTube for us to do. And what we are doing on Saturday by 3 p.m. is COVID-19 and pregnancy, approach to antenatal care and management. So that will be taken by the Limel team, the O&G team. Please book your space ahead of time because we typically have limited spaces for this. Okay, so let me try and go back to the pathophysiology. Somebody asked for the pathophysiology again. And essentially what we're saying about the pathophysiology is simple, is that autoregulation is at the center of hypertensive crisis.
Who is there? Who is there? Eh? Come to the other door.
About how it works. So you have to look at this and then know how it works. So when the blood pressure, the mean arterial pressure is within this level and this level, the body is able to control the blood flow going to it. And how does it do that? It does that by modifying the smooth muscle walls of the arterioles. So when it adjusts that, it's able to adjust peripheral resistance. That adjusts peripheral resistance and that affects blood flow irrespective of the blood pressure. So at mean arterial pressures up to 150, the body is able to still tolerate it. In a hypertensive, however, the body is able to tolerate even much higher mean arterial pressures. So a chronic hypertensive may be walking around with 200 over 150 sometimes, and it's seeming okay. But in a hypertensive encephalopathy, there's a sudden rise in this, and because the body is unable to manage its own blood flow, this autoregulation, if you adjust that blood pressure too sharply, then blood flow will suddenly be reduced. While in this case, even if blood pressure while it is still within this curve, even if blood pressure drops suddenly, the body will increase it in a way that you can get more blood flow. Okay, so in this case, it's a little bit different. So that is the central pathophysiology. Now, I remember I told you that what happens is that there is a trigger that happens. So also one of the ways that it happens is that something stimulates decrease renal perfusion is felt. Okay, so the kidneys all of a sudden feel that renal perfusion is decreased, either due to afferent arterial stenosis narrowing because the kidney felt something, so it becomes smaller, and then tubular concentration is reduced. That now stimulates aldosterone. This process stimulates the RAA axis, renin-angiotensin-aldosterone axis. That increases fluid volume and makes sure that the blood pressure is uncontrolled. Now, when the blood pressure becomes so uncontrolled and the autoregulation fails, the end organs start to get damaged. As they're getting damaged, they begin to release inflammatory markers. That leads to further endovascular injury, and that causes fibrin necrosis of the arterioles. Okay, so this now continues as a rigorous cascade to all of this. I hope that answers the question that they asked. Okay. Do you have any other thing to add, Dr. Officer?
No, to the pathophysiology, no. Okay, but to the atherogenic index and prevention of myocardial infarction, I think the person posted the question again, so I think I can say it clearly now. Okay, so basically, what we emphasize is that in cardiovascular risk reduction, we take it in the context of the overall cardiovascular profile. And yes, of course, the atherogenic index is one of the indices that can be used to estimate the cardiovascular risk profile that a particular lipid panel portends, okay? But it's often more beneficial to estimate the overall cardiovascular risk and make a decision on whether the patient should be on a statin or not, and whether the statin that the person should be on should be a high intensity or a moderate intensity statin. So that's usually more valuable. Okay, but if you calculate the atherogenic index of a patient with existing hypertension, and if the index suggests a high risk for the patient, because usually when you calculate that, that is a low risk, high risk, or intermediate risk. If it's a high risk, then definitely that person should be on a statin, okay? But in our practice, we often use the ASCVD risk estimator, and based on that, we decide whether the person should be on a statin at all, and if the person should be on a statin, whether we should use a high intensity dose or a moderate intensity dose. So I hope that answers that question. Thank you very much.
All right. Okay, thank you all. I think we have more or less answered all the questions, except there's a burning question. Thank you for attending this webinar. We hope it is of much value to your practice, and that patients get better because of it. We've shared some very valuable tools from our practice, some examples. We hope that we can do some cases in one of the webinar series during this COVID time. CardioCare is still open. We're still doing angiographies. We're still doing tests, because if somebody has a heart attack, we still have to do it. We're still treating strokes. Like I told you, we admitted with a hemorrhagic stroke, and follow the same principles. Once you follow the principles, you will not run into trouble. You typically will not run into trouble, but you must also know the limit of your facility, the limit of your knowledge, and the limit of yourself. Every patient is different, and you must know when to refer, when to ask for help, when to seek specialist inputs going forward. So thank you very much for joining, and with this, we'll come to the end of this program. If you look at the screen, you will see that we've put the email address if you want to contact for CME points, or if you have any questions or any other things, you can send the CMEs there, the questions there. If you have any problem connecting to any of our the website, the phone number is there via WhatsApp, and on Facebook and Instagram. Follow us. All our by the time the thing is launched, it's always there. And on YouTube, the Living Hospitals Network. The webinar we did last week on approach to a patient in difficulty in breathing, very fantastic in-depth webinar done by Dr. Alfisoye, is right there on YouTube. I've put it in the chat box. So if you look at your chat box, if you scroll through your chat box, if you look up, you will see that I put the link for last week's webinar right there. So you can click on it and go straight to YouTube and follow it. Also subscribe there. So every time we do a webinar, whether you miss or not, if you go there, you may be able to catch up with it going forward. We will also try and see a way, I don't know how we'll do it, to share the the presentation in PDF format. If you're going to reuse the presentation, please do give necessary credits, but you are free to use it anyhow you feel, anyhow you wish. Don't hesitate to share with other doctors. I think it's a valuable resource for Nigerian practitioners. So don't hesitate to share this link, Facebook and YouTube, so that other people can rewatch it, or your team can rewatch it. And then you can always refer to CardioCare whenever you have a patient that you think you have trouble managing. Here in Garki, we are 90 minutes from anywhere from Nigeria. And if you have an MI or something, need a pacemaker, diabetes, all our specialists are on ground to take care of that. God bless you. Have a nice day.